Ask a hospital patient to name their number one wish, and most will say, I wish I were home right now. These days, as an increasing number of hospitals and health systems rethink their care delivery models, that wish is starting to come true. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly with AHA Communications. Many care providers these days are considering an acute hospital at home approach as one of the safest and most effective care options for certain patients and conditions. As a result, the hospital at home care model is emerging as a promising and transformative approach to improve patient outcomes and experience. Join us to hear how Palomar Health's transformational acute hospital care at home initiative is delivering great care to select patients in the environment they like best, their own homes. Palomar's clinical operations redesign was ready in just 6 months and has already been granted waiver approval from the Centers for Medicare and Medicaid Services. Today's podcast is brought to you by Guidehouse.
Hello, I'm Nancy Foster, Vice President of Quality and Patient Safety Policy with the American Hospital Association. A growing body of research shows that hospital at home is an effective strategy that improves all three components of the value equation: improving outcomes, enhancing patient experience, and reducing costs. Establishing a successful hospital at home initiative requires reimagining aspects of the care delivery model along with significant investments in people, process, and technology. And more recently, it will also require some initiatives by the federal government. With me today are Sheila Brown, a registered nurse and the executive of strategic priorities for Palomar Health, and Donna Cameron, partner in the health segment with Guidehouse. They're here today to talk about Palomar Health's transformative acute hospital care at home initiative. Let me start with the first question. Hospital at home initiatives can truly transform the way care is provided and are becoming higher priorities for the field. However, the structure and implementation of these programs can vary greatly. How does a hospital at home approach fit into the care delivery model? How is it able to enhance the care experience for patients and their families, as well as the caregivers themselves? Sheila, would you get us started?
Absolutely. Thank you so much, Nancy. And Palomar Health, the largest hospital district in the state of California, are and have two emergency rooms where we were seeing around, and as of today, around 300 patients a day. And when we began to look at our healthcare system and we were challenged with some of the capacity issues, we knew we had to look at our care model that would support the patient receiving care in their homes. It was important to us to be able to pursue this because we were having capacity issues with our inpatient volume, and we needed to improve the quality and outcomes with our patient experience. And we knew that it would be important if we mobilized this program. So we engaged our Guidehouse team members and went to them for their expertise and looking at the process of how we can come to terms and apply for waiver approval with CMS. And looking at that and deciding to pursue the waiver, we felt it would be better and it would integrate the patient in the care process with the new model at home, thereby helping us with our capacity issues at our hospital district.
Thanks, Sheila. It's been interesting as we've seen health systems like Palomar adopt acute hospital at home models and what types of challenges they're trying to solve for. What we know from Palomar Health, and you heard Sheila say that one of their opportunities was to look at hospital capacity. When we had an increased demand for inpatient beds, particularly during the pandemic, a number of hospitals began to think about how could they shift a care model that was home-based and provide acute level of care. And when CMS offered the waiver for organizations to do hospital at home, it created an opportunity for organizations like Palomar to say, how could we provide acute level of care in someone's home to allow the patients that really needed to be in the hospital to be in the facility within the walls of the hospital, and really target some patients that could successfully receive high quality care where they would be highly satisfied in their homes. And that's where we've seen a lot of accelerated adoption of this program.
That's great. Thank you both. Sheila, would you say a bit more? Why has this initiative been so crucial to Palomar Health as it's redesigning its care model for better care of its community?
Well, Palomar Health being challenged with the actual capacity issues that we are having, we also wanted to leverage the services we offer at Palomar Health. We've been fortunate enough to have a continuum of care. We also have the ability to not only see the patients within the hospital, but we have a skilled nursing facility. We also have a home health agency, as well as outreach programs. And with that capability, we wanted to leverage that opportunity to service our patients where was going to be best for the patients.
Great. Donna, is what Sheila's describing typical of the kinds of hospitals or health systems you've been helping, or is it slightly different?
I think a number of hospitals really have been dealing with the challenge of hospital capacity, but we've also seen that some organizations have different issues that they're trying to address on behalf of the patients they're serving. One of those things may be chronic condition management. So a lot of times we see patients, common patients in hospital at home that may have CHF or COPD, pneumonia, that end up back in the hospital. They go back to the ED, get admitted to the hospital. And because their condition is chronic, there is really the ability to begin offering some alternative models for those patients in their home and then wrap around other services so individuals can actually stay out of the hospital setting. Readmissions have been a big driver. When Guidehouse looks at readmissions, most hospitals have been thinking about 30-day all-cause readmissions because that's a metric that they need to measure on an ongoing basis. So as we look at patients, particularly patients that have Medicare, for example, as a payer, and we look at 90-day readmissions, we begin to see that these chronic patients with chronic diseases tend to get readmitted within that 90 days after a hospitalization. And it makes it very important to begin to think about how to create a continuum of care that allows people to receive the care that they need in their homes, both through hospital at home, but also as other services are offered following that service.
Very interesting. It makes that continuity of care more continuous. Very interesting point. Sheila, it would be rare for anybody to launch a new initiative and have everything go smoothly. Could you say a few words about what the biggest challenges you were facing were as you launched this initiative?
Absolutely. One of the biggest challenges is we were in COVID. We were also setting up a federal medical service. So you can only imagine key stakeholders within the organization were really involved in dealing with the pandemic, as well as looking at the realities of pulling everyone together, because that's what this required, to get into the same room and talk about what it would take to be able to deliver patients' care in the home. The challenge was when you brought the team together, we wanted to make sure that our physicians were involved. One of the challenges we had was making the staff and the physician aware whatever we put in place, it had to mirror what we were doing in the inpatient setting. So as you can imagine, when you're used to caring for a patient in an inpatient setting, now having to transition that patient home, yet still have the inpatient setting procedures and policies in place that require the entire organization our physicians, our nurses, our quality department, our FANS department, our pharmacy department. It required the entire team to come together during COVID and talk about how we were going to care for these patients in their home. The other challenge that we had was making sure that we were able to do and provide safe patient care. We needed physician champions. So I'll give you an example. Our emergency room did not have a physician champion. So we had to really identify the appropriate physician champion in our emergency room, because a lot of the patients that were coming to the hospital, they had to make the determination at that time, were they coming to the hospital related to their chronic illness? Was this something that could be cared for in the home? We also needed the physicians to come together with the entire medical executive committee to determine what would be their development of inclusion and exclusion criteria for the program. This program required a certain type of disease management based on the DRGs. It also required patients who had family that could be at home with them. It also required how far did we want the patient to be away from the hospital in case there was an emergency and the patient had to come back to the hospital. So it required to have those physician champions, not only from the emergency room, but also from the ICU, from the hospitalist side, as well as our medical directors and chief of staff. The other challenges we had to also look in creating this program during the pandemic was looking at how do we accept getting state approval during our time in the state of California, where unions were picketing around the hospital at home because they said it had a lack of safety factors that were included at the hospital at home program. So there were a multitude of variables that were considered challenges, Nancy, but we were able to mitigate those challenges just by bringing in the right team and the right stakeholders together as we plan to deliver this care in the patient's home.
Sheila, to build on what you're saying, one of the things that I think becomes really important in designing a hospital at home program is how do you bring together that multidisciplinary team of various stakeholders that can begin to think about providing acute care in a completely different way. And it really begins to challenge a lot of our historical paradigms, what we think about when we think acute care. So when you're thinking about your staffing model, how are you going to get nurses or clinicians into the home? How are you going to leverage technology? How do you get pharmacy into the home? And how do you do certain procedures that when you're in the physical facility of an acute care hospital, you have to rethink how to do a lot of those things. And so getting the buy-in and engagement, not only from the physicians and a number of the other functional areas, became important. I also want to highlight that based on Guidehouse's experience with Palomar, having an executive champion is incredibly important. And Sheila really led the team and led that kind of change management process and kept the patient at the center of that. So as people were saying, well, that's not how we've done it in the past, or how might we do that? It really was important to have an executive leader as well as that team behind designing the program. And it really was energizing, I think, for the team to think about how they could serve their patients.
Thank you both. You've incredibly described not only the challenges, but many of the keys to success. And I love the way you were talking about helping people within the hospital who are trying to anticipate how they would take their normal processes and build them out to serve people in their homes, really help them think through those protocols with a champion engaged to make that happen. Those are truly important for those who are listening to this podcast who will want to create their own hospital at home program.
Nancy, one point that I did want to bring up is not only having the key stakeholders, but also having a diverse population of key stakeholders. And what I mean by that is Palomar not only engaged the inpatient hospital employees, we also had our fire department, our EMS, we had our community leaders, we had our police department, we also had definitely our home health staff that was very much involved into how they cared for the patient in the home. So when we were able to bring the diverse staff together who really had the skill set in those environments and begin to leverage the skill set for our inpatient and the diverse group, it really drove home the point that we were able to take care of these patients in the home, and everyone on the team were able to get to that agreement by having a diverse stakeholder involving the community.
Sheila, what an incredibly important point that you really have to reach outside the normal bounds of the hospital in order to make this work effectively for all. Donna, is that something that you're seeing other hospital at home programs, acute care at home programs do as well?
Yes, we're seeing partnerships and collaboration beyond the walls of the hospital that really are benefiting patients. I mean, as Sheila mentioned, as you think about the processes that you have in place, the contingency plans that you have around making sure that patients receive high quality care, having those discussions with those community entities, as well as bringing them together with the hospital staff, and even in Sheila's case at Palomar, it was important. They had a very active involvement from their home health leadership and their home health group. But this was a different program. You know, it was acute care in the home. It wasn't home health plus. And so I think as you bring people together and begin to think about how could we serve patients in a new way, it was exciting to see how the innovation and the redesign occurred, again, with making sure that high quality care was provided at all times.
Sheila, taking you back a moment, you mentioned that this happened during the pandemic and was made possible by CMS's waiver program. Can you talk a little bit more about how that fit into Palomar Health's initiative?
Absolutely. When we were looking at the delivery of care model that we were doing, we engaged CMS. We engaged the CMS team in all of our processes that we were doing. We also looked at how we were going to mirror the patients in the home that would be approved by CMS. So we had weekly calls with our CMS representatives. We also engaged our local CDPH, which is the California Department of Public Health staff, to let them know what we were doing prior to getting approved through CMS. We also looked at how we were going to be able to deliver that care, making sure as we took our steps into this approach, we engaged the CMS in all of the steps we were taking. An example, we were looking at patient remote monitoring. We know that that is important because we needed to have that technology present in the patient's home for not only the nurse, but for our monitoring that would take place after the nurse was there with the patient. So, patient remote monitoring, we wanted to make sure that we were engaged with our policies, our processes, and procedures. So, when we spoke with CMS and when we spoke with CDPH, they were in partnership with us as we began to get those processes approved.
So critically important to bring those agencies in and work with them. I know when I talk to the folks at CMS about the acute care at home program in general, they are very big supporters of what's been happening thus far, and eager to think about how this might be extended. Donna, is there anything you'd want to add in terms of how this might have played out in other locations?
Happy to do that, Nancy. It's interesting because I've worked in healthcare almost 40 years. And I think one of the big takeaways I have from the experience that we had during the pandemic is that there was really an acceleration of innovation to ensure that we were able to care for patients, not only that had COVID, but for the total population that had healthcare needs during that period of time. When CMS offered the waiver to do acute care at home, it really was a mechanism for hospitals to transition patients that they could appropriately provide acute clinical care in the home to create that capacity in the hospital. And they also supported that waiver by allowing a funding mechanism in place for Medicare patients to still be funded if they had been approved, if an organization had been approved. I think what we're finding through that innovation is the CMS waiver was approved during the public emergency period, which has been extended a number of times and now extended through January. And organizations have paused and saying, can we afford to make the investment in this new innovative care model? And will there be long-term sustainable funding for us to be able to do that? And I think what we're beginning to find through the measurement that's occurring is not only is this program showing that there are certain types of patients that can be very successfully served in their home, we're also seeing that there's a high level of patient satisfaction. Clinical outcomes are very positive. We're seeing a reduction in length of stay. We're seeing, up to 24% reduction in readmissions, lower mortality, and a lot of metrics that are beginning to create a value proposition that there's another way to provide acute care to certain populations. And so I think there is a lot of advocacy at this point that this new care model that really became much more prevalent following the pandemic, although there were programs in existence prior to that. The health systems that we're working with and a number of other organizations are really hopeful that CMS and other payers will recognize the value and the viability of this level of care to support it long term, even after the public emergency period ends.
Well, and if I may, the issue you raise is so important. You may know that AHA sent a letter just the other day to the Hill asking Congress to take action to enable CMS to extend this program so that we can build out a permanent program that is even more flexible than the waiver, allows more things to be done in the home. Uh, but but the problem is there is not a uniform collection of data so that we can highlight the value of all of these different programs that have been uh, launched during the pandemic. So we need individual hospitals to talk to their congressional delegation about the benefits they're providing to the people in their state, in their community. Speaking of that, Sheila, would you help us? What are you seeing as the enduring value or benefits for patients and your workforce, if there are some, to the hospital at home program?
Absolutely. We are able to see the engagement with our relationship with CDPH. That's very important because of the importance that they see from this experience. We had the day to basically have a day in the life, and we engaged CDPH as well as our other community leaders. And what we did was we identified the learnings and we've refined and adjust our workflow. But what we heard loudly from this, Nancy, was the patient feedback. And the patient's feedback was incredible. When we did the day in the life, where we actually went through this, the main feedback was there's no place during COVID that I would want to have this experience but in the home. And to be able to have my loved one who has the capability to work with the nurse and your staff and the EMS from the community EMS system, it really mattered to that patient when they were going through their challenges to have that care at home. So I'm seeing the community really embrace this, especially when there's times such as COVID, or not times such as COVID, but they're having chronic episodes, to be able to have a determination to have that care at home. When we're looking at the actual financial impact to this, my advice to anyone would be to start small, to look at what we're doing on a small level, because that is important as we begin to develop these care models. When we start small and we're able to see patients and we're doing remote monitoring versus 24-hour nursing care, you're able to really see the impact not only in readmissions decreasing, quality, patients being happy, but you're also able to see it in the cost of care for those patients that have the chronic illnesses.
Thanks, Sheila. Donna, would you add anything? And if you have anything to add to Sheila's terrific remarks, would you also focus a little bit for me on the family? What are you hearing from various programs about the reactions of the family members to having a very sick individual at home?
I think we're finding that as our population is aging, and I frequently say I'm a proud baby boomer, there's a lot of momentum right now for aging individuals to want to have care available in their home. This isn't a program for every type of patient, and Sheila referenced earlier that it's important for an organization to be thoughtful around the types of patients they're going to serve, their inclusion and exclusion criteria. And based on how this program is being deployed by health systems, we're already seeing that there are good outcomes clinically. Patients are happy. Families are supportive of this program because they see the benefit of having their family member in the home. And also we're seeing it related to how the quality relative to the cost of care continues to be favorable. I think it's important whether you're a hospital administrator, whether you're a clinical leader, whether you're a physician, that as you think about the sustainability and the kind of the business and clinical case to sustain this program, there's really a win-win. As we see organizations, as Sheila mentioned at Palomar, that can move certain types of patients to be served in the home, it creates capacity and additional ability to fulfill a mission to serve more patients. That also gives the hospital the ability to have additional patients and additional revenue that maybe they would not have been able to serve if the hospital is full. Readmissions, we're seeing that if you think of it in terms of financial considerations, readmissions, and every organization really establishes what they have in terms of a financial value of a readmission, taking into account whether they're in fee for service or value. We're seeing a national average around $16,000 impact for a readmission. So you really can begin to see that if certain types of patients are coming back to the ED and getting readmitted again, and you can offer services to successfully serve them in their home and then make sure that they transition to other supports after that, there is a financial benefit to reduce readmissions. But honestly, as a clinician, it's better for patients. It's better for families. It's better for quality to have an avoidable hospital admission prevented, and someone continue to get the care that they need and see it as a high quality option for them.
Thank you. So let me take a future lens on this. Now that hopefully the worst of the pandemic is behind us, as we're recording this here in the fall of the year, we're seeing an uptick in admissions for upper respiratory diseases, a variety of them, but thankfully we're not overwhelmed with COVID patients. We may be returning to a more normal pattern of hospitalizations over the course of the year. So, Donna, you mentioned capacity and the importance that was to us during the pandemic. But What would you say to hospital leaders if we do return to this more normal hospitalization pattern? Why should they consider establishing a hospital at home program in their own organization? What benefits would you point to that they should consider?
I think it continues to point back to what we talked about earlier. What are the operational challenges that you're having? What are you trying to solve for? And who are the types of patients that you can put solutions in place to address through new care models? For some organizations, and we see variation in markets, some hospitals, particularly large hospitals in metropolitan areas, are seeing a lot of capacity challenges because not only are patients showing up to the emergency room, perhaps because they don't have a primary care physician, and then they meet medical necessity to be admitted. Is there an alternative option for some of those patients that could be served in a acute care at home type of a program? But we're also finding that patients are staying in the hospital longer relative to benchmarks. In many cases, a lot of hospitals are seeing increased length of stay challenges. And many of those length of stay challenges are related to patients that need additional services after acute care. And it's been much more difficult to do an efficient discharge for a variety of reasons, some of which has been related to new protocols and processes put in place because of COVID. So I think there are market differences, there are individual health system differences, and I always come back to what are you trying to solve for to be able to provide the services to your patients? And if it's let's create the capacity so we can serve more patients in the walls of the hospital that need to be there because of the severity of their illness, or are you trying to solve being able to have an option for certain types of patients to be served in their home with a higher level of satisfaction to achieve the quality? Are you trying to solve for some of the workforce challenges? We're seeing profound workforce challenges and workforce costs. And the acute hospital at home model really gives you the ability to begin to think about your staffing model. Do you think about your staffing model just with RNs that you already tend to be short with in the hospital setting? Or do you think about RNs? How are you looking at other types of providers? Some programs are looking at how do they leverage paramedics. Some programs are really looking at technology and virtual care in a way that's providing access to accomplish the same clinical outcomes, but being done in a different way than kind of the historical way that we've provided care in an acute care setting.
Thank you, Donna. That was comprehensive and fascinating. Sheila, I'm gonna ask you to address one particular issue you raised at the beginning of this conversation, which is you mentioned that in California there were nurses picketing, concerned about the growth of a hospital at home initiative. In your experience, has that turned a corner? Are the nurses more convinced that they can be part of a team that successfully delivers high quality care in the home?
I believe at this point, the nurses and their concern will be there until our state CDPH agencies, as well as the regulatory guidelines from the state of California, approve this delivery of care model for all hospitals in California. We're still in that process, Nancy, and I think it really matters that we have our processes in place that matches up to our state regulatory guidelines. Once that has happened, I believe the nurses in California, understanding that the rags are very tightly measured, very similar to what we do in the inpatient, there will be that level of acceptance. At this point, we're still working with our state regulatory body. We're still looking at our processes, and we're pretty close at this point of getting those items approved.
Thank you, Sheila. You are, I believe, correct. In my experience, too, it's important to have those oversight processes in place to give confidence not only to the public we serve, but also to our colleagues, our staff, that which we are doing meets all appropriate standards to deliver that high quality care, safe care that they are committed to delivering. And when those things are in place, people feel more confident that everyone is delivering the kind of care that should be delivered to the patients we serve. Sheila and Donna, I want to thank you for joining us today for a really important conversation that has touched on so many different features of the acute care at home program, the hospital at home program. Your insights and thoughts really will help other AHA members as they think through how they deliver care. Thank you so much. If you'd like to learn more about Guidehouse, please visit www.guidehouse.com for additional assistance on how you can restructure your program.